Greetings, everyone. Welcome to Digital Health Tools and Health Equity Lessons Learned and the Path Forward. I am Mitchell Blunt, Research Assistant in the National Center for Primary Care at Morehouse School of Medicine, also known as the NCPC. We are so excited to host this important conversation. Eligible attendees can claim CME credits by clicking the link in the chat or scanning the QR code on the screen and enter activity code 11811. The objectives of today's event are listed on this slide. This event is part of the Digital Health Tool Study conducted by the NCPC and in partnership with the United Health Foundation. To assess the adoption and use of digital health tools, we are conducting a survey of primary care clinicians serving in Georgia, Kentucky, North Carolina, and Tennessee. If you are a clinician serving in these 4 states, please take our survey. You can access the survey using the link in the chat box. It is my pleasure to introduce Dr. Dominic Mack, a family physician and director of the NCPC. From leading the integration of telehealth to providing healthcare access to the Gulf Coast post-Hurricane Katrina, to bringing resources and technical assistance to more than 5,000 small, rural primary care practices across Georgia in their adoption of electronic health records, Dr. Mack has dedicated his career to supporting patients, communities, and his fellow primary care clinicians to achieve health equity. Dr. Mack also leads the National COVID-19 Resiliency Network, a national network of partner organizations aimed to mitigate the impact of COVID-19 on racial, ethnic minority, and other disproportionately impacted communities. Welcome, Dr. Mack, and thank you so much for your leadership.
Thank you, Mitchell, for that kind introduction. And I want to welcome everybody today. The NCPC mission is strengthening the primary care system through education, research, and training to improve health outcomes while advancing health equity. As you all know, the COVID-19 pandemic has devastated communities across this country and the world. I heard someone say that pandemics and disasters disproportionately impact the same communities the same way every time. That may be true. However, despite the severe health consequences of this crisis, we must strive to develop new strategies to ensure that this time the outcome is different. We must provide solutions to correct the historical and systemic issues that have contributed to health disparities since before the US's first pandemic in 1918. This event and our digital health tools study are so important to understanding and address disparities in adoption in the use of digital health tools. We've studied rural and urban primary care practices and know that under-resourced practices that typically serve underserved communities have and continue to struggle to adopt and use digital health technology, including wearable devices, electronic health records, and telemedicine. These gaps severely limit the benefits technology could provide in disproportionately impacted communities that are serviced by primary care and specialty practices. The COVID-19 pandemic spotlights existing gaps in the health system, and we are working to identify those shortcomings within the system. However, MSM is also providing solutions to support primary care clinicians who are committed to serving their patients and communities throughout this public health crisis. Clinicians have been rapidly adjusting to the limitations posed by COVID-19, many using telehealth for the first time. Health systems, hospitals, policymakers, and payers are partnering with communities, innovating and relying on digital health tools to ensure access to healthcare services. The U.S. health system is evolving, and today we will discuss successful innovations, but also the challenges that we must overcome through new solutions. You will hear from an esteemed panel of experts working hard to support communities, primary care clinicians, and health systems before, during, and after this COVID-19 pandemic. They will share their work, lessons learned from the COVID-19 pandemic, and will help set us on a path for moving forward. I want to thank our panelists for the work they do and for sharing their time and wisdom with us today. A special thanks to United Health Foundation for supporting and collaborating on this effort. We thank our team here at MSM for supporting and working diligently on the Digital Health Initiative. And last but not least, we thank you, the audience, for attending today. I will now introduce Megan Douglas, Director of the NCPC's Health Policy Division. Megan is an attorney and faculty member at MSM. Her research focuses on measuring the impact of laws and policies on health outcomes and health equity. She will introduce today's panelists and moderate the discussion following their presentations. Thank you again for joining us today.
Thank you, Dr. Mack, and thank you to the audience, and thank you to our panelists as well. I have the pleasure to introduce our panelists today, and will moderate the discussion afterwards. As has already been mentioned, this year really has brought a lot of challenges, but I think what we'll hear today are some of those challenges, but also some of the opportunities that we have to address longstanding problems with our health system, and recognizing and understanding the role that systemic racism has played in the health inequities that we're seeing related to COVID and that we have seen for the last several centuries. It is my pleasure, and I'm so excited to have our panelists who have agreed to share their wisdom and expertise with us today. They represent several different disciplines and sectors and have been working tirelessly during the COVID pandemic and before the pandemic to support health professionals and communities. We'll have a chance to discuss the lessons that they've been learning and to discuss some future directions. Please remember, we will take questions from the audience at the end. So if you do have questions, use the Q&A box to submit those questions for the panelists. So first today, we will hear from Dr. Rebecca Etz, co-director at the Larry A. Green Center and faculty at Virginia Commonwealth University. Rebecca is a cultural anthropologist and has been leading a weekly survey of primary care clinicians throughout COVID, and we'll hear more about that survey and their findings today. Next, we'll hear from Dr. Michael Petersen, Health Innovation and Health Equity Lead at Accenture Health. Michael Petersen is an emergency medicine pediatrician who works with health systems and practices to address health disparities and social determinants of health. And he'll talk to us about some of the strategies and innovations that have been critical to mitigating the impact of COVID on communities. And then finally, we will hear from Mr. Philip McKoy, Digital Transformation Leader at Optum. Mr. McKoy was the Chief Information Officer for United Health Group prior to this role, and he will share some of the ways that digital health tools and innovation have been driving change within the health system and how these changes are improving access to care for patients and communities. Rebecca, go ahead and start with your presentation.
Thank you so much. Pleasure to be here. I really appreciate your time today. Glad to have everybody here. The survey we've been doing has been fielded weekly from March until end of June. And then after that, it's been bi-weekly. We have collected about 20,000 clinician surveys through the survey, and we've also done one with patients. So we've collected about 9,000 patient surveys. I'll be providing information from both of these things. I provide a little bit more information on the screen here about what the survey is and who's funding it. We are, of course, always thankful to our funders. First, I wanted to have a common understanding for what primary care is. And I know you're probably used to hearing the traditional Barbara Starfield 4 C's or some combination of coordination, comprehensiveness. I like to make it a little more real, a little more person-centric. Primary care, as we know it today in the US, was born of the civil rights movement. And so I like to put a human understanding on it. Primary care is about having clinicians that are worthy of your trust. They are about having the wholeness of your dignity in mind, and they're about putting patient interests first before our own. When we think about this, we look at what do we see happening through the survey in primary care as the pandemic has gone on. So for patients, the pandemic has meant that health is dropping. And what we have here are clinician reports of how their patients are doing. And they say that their chronic conditions during the pandemic are getting worse, that their mental health has decreased. And you see the scale on the bottom, over 80% have seen mental health decrease among their patients. Their physical health has decreased. The visits themselves not only have more complaints per visit, but also are of greater complexity. And the reduction in self-care among patients is really noticeable. So in addition to health dropping, we also see that the impact of inequities is growing. The rates of substance use, of domestic violence, of financial insecurity, food insecurity, and housing insecurity during the pandemic has increased. And I'd like to point out that primary care is that platform that has relationships with their patients. They actually know these things because they ask them about them. So they not only know them, but they know that they've been getting worse. They try to solve them. Primary care itself is experiencing burdens as well. Its finances are strained. So right now, it's actually better than it was at the beginning of the pandemic, but it's still pretty awful. 30% or more than 30% of work is unpaid. Fee for service volume, that's how most docs get paid, is down by 30 to 50%. They have furloughed in 50 to 60% of their practices. They have positions they can't fill even if they wanted to. And most often, primary care tries to stay open. Their thoughts are about the patients first and how we can help the population, and they know they're going to get in a pinch. So they stay open as much as they can, and they do that by doing things like deferring their salaries. One of the most common solutions to saving cash at the beginning of the pandemic was for clinicians to simply stop getting paid. But it has been a long haul, and over time, it's caused drain. There are now over 20% of the workforce is thinking of leaving primary care. In addition to the financial strain, then, the mental stress is real. 48% say that burnout is at an all-time high. So it's not just that they're stressed, it's that this is the worst situation that they've been in throughout their careers. It's not just affecting them, it's affecting their physical health as well as their psychological health, but it's also affecting the well-being of their families. Not only with the stress that happens at home, but also because of their outages due to illness, and also because of what they feel is a potential risk of bringing the virus home to their families. One of the questions that often comes up is, has primary care rebounded since the start of pandemic? It seems like visits have gone up and revenue is recovering, and doesn't it seem like things are getting back to normal, and now all we have to worry about is backfilling in the hole? And the answer to that one is a patent no. We actually asked it of our clinicians, and 97 of them agreed, no, the rebound isn't here. And actually 81% of them did it with some salty language. It's very rare to get 97% of a platform agreeing in anything. 47% said, hey, look, our practice might be financially stabilizing, but we ourselves as a workforce are clinically fragile. There's good reason for that. One of the things that we look at, and I'll come back to the reason, but one of the things that we look at happening is digital health. So for telehealth, what we focused on in our surveys was specifically video use and phone use. In the beginning, we talked about e-visits. There was a lot of confusion among respondents about what an e-visit was and how it was different from messages through portals. So we focused our questions on video and phone in order to get a clear image. What you see here is from April 10th through June, the percentage of video-based visits in blue and the percentage of phone-based visits in orange that were happening for a majority of practices. So in other words, this is saying that close to 50% of practices were using phone for the majority of their visits at the start of the pandemic, and about 35% were using video. That percentage went down over time, but is still an important life stream to practices. Telehealth itself can be a mixed bag. So I know that there are many people that feel like it should be all or nothing. I think that's never true for anything. It's not that black and white. So what does it mean? Well, we asked our clinicians, what is video particularly well suited for, and what are phone visits particularly well suited for? This is an important thing to do because we know, for instance, that there's still 12% of the population that doesn't have access to computers or broadband. We have to have a way of reaching them when we're in situations of lockdown and needing to provide care and support. So what we see here is the different types of care that are happening that they've found video and phone to be most useful for. You'll notice many of them have to do with talk therapy or being able to provide counseling, but there are other things like the worried well who are nervous during a pandemic, or the check-ins for stable chronic conditions. This still presented a mixed sort of picture, and sometimes it felt like we were somewhere between lost and very lost. So I have some positives and some negatives here to offer. On the positive side, face-to-face visits were down in primary care, but patient contact is at an all-time high. There's a need and an outreach going both from the practices to patients and from patients to practices, and it's digital health solutions that made that possible. Patients struggle with isolation, they're struggling with anxiety and depression, and the technology, as you saw on the previous slide, allows patients to connect well with their clinicians. That said, you still have the percentage that lack access to technology. You have insurers that have pulled back on funding for telehealth, and therefore clinicians that have pulled back on use. I think the pullback on use is a particular detriment. Now, I only have about a minute left, so I'm gonna go through these slides quickly, but you can ask me anything afterwards. Relationships really are the bedrock of primary care. So it's important that we notice that clinicians identify that and say, this is the most meaningful thing I do, and patients specify what it means. And it means making sense of things and having somebody who simply makes me feel better. What we saw then is, what did this mean during the Black Lives Matter and during the killing of George Floyd in particular. So after the killing of George Floyd, we asked both patients and clinicians whether racism affected their health, whether structural racism was a public health concern, whether this was something that primary care could help them with. And I'll just point out a couple of things here on the screen. They overwhelmingly said yes. I want to point out that 84% of patients say that racism affects health. This was not a sample that was oversampled for minority patients. This is the population and what they believe. You have 15% of patients who called primary care because something was going on in the news and they just didn't know what to do with it. You saw clinicians seeing physical symptoms simply related to racism. It's a real concern, but through this trusted relationship, they could work together. That's it. So I just wanted you to grab a look at our funders again, and happy to answer any questions afterwards. Thank you so much.
Hi, everybody. I didn't know I was going to wait for Megan to tell me to go ahead and go. Mike Petersen, it's an absolute pleasure to meet with the people who are really doing the heavy lift and hard work on the front lines of healthcare. So thank you for all you do. I'll start off with a quote by Frederick Douglass. There's a prophet within us, forever whispering that behind the scene lies the immeasurable unseen. And I say this as a sort of call to action and a reminder as for all of us as health leaders and providers that we serve communities, but as a call to action that we see the connectivity between the large landscape, especially in light of the recent pandemic or current pandemic, but how important it is for us to remind ourselves to have a clear vision on the communities, the families, and the people we're serving. So I always say, if not now, when? So as we think of health equity and the social determinants of health, what we saw in this pandemic is not a surprise, as Dr. Mack alluded to, which is that in crises, in disasters like Katrina, Hurricane Katrina, and in pandemics, earthquakes, tornadoes, people who live at the margins, people in vulnerable populations are the ones who are impacted negatively. And what we've seen here is we have a pandemic on top of an epidemic of poverty, a fractured public health system, among other things, a fragile supply chain within our health system. And even in the models of care seem dated. So what this slide is really alluding to are that the key takeaways are that the pandemic, not as a surprise to most of us in healthcare, is really negatively impact people of color. And not just in the urban centers, but also in rural populations as well. They are just devastating. And what we also have noticed is that a lot of us were working pre-pandemic on these efforts. And it took this pandemic to accelerate, as Karen DeSalvo says, public health officers and public health workers have a voice because their role in this pandemic has been so vital and important. But more importantly, it's also the role of the clinician, the frontline primary care physician, because at the end of the day, I'm going to share a view on what the industry's been doing, even though it's around technology and algorithms, data. At the end of the day, we're really talking about human connectivity and human relationships, as Dr. Ertz just alluded to. And we're talking about trust, which is the biggest factor, of which you are all vital part of. And so why is our system broken? Well, we know one thing's for sure. Healthcare is the last to evolve. If any of us have been through, I would dare say it, an Epic implementation or an EHR implementation, just the cultural transformation of that event and experience, it disrupts our way of thinking and delivery of care as clinicians and frontline workers. Can you imagine now, in the same vein, what it's like to try and manage a pandemic with no PPE and all of these things? So what this pandemic has done is it just exposed and illuminated these graphic fractures in our system that really have to do with, some of it is a lack of investment, just in the way we practice healthcare. Sometimes it's around instead of a proactive, all our primary care, they don't have that primary care thinking, right? Let's talk about wellness and preventative care, which is our mantra. But what we're hearing, what we see as an industry in the United States, is that we're very reactive to these issues. So a lack of infrastructure really does describe the supply chain, not in just the deficit in resources such as nurses and doctors and other healthcare workers. We're also seeing that the untoward events of this or impacts really impact people of color, especially as it relates to the social determinants of health and being able to provide basic needs. Transportation. Those who live in food deserts are already challenged because of the stay-at-home orders to get food. They don't have access, as Dr. Ertz reported, because of the digital divide, to broadband and other technologies to even order Uber if they even could afford it, to get a ride or have food delivered to their homes. So we're seeing this fracture in health equity grow in the United States, and it's evident by key issues that we all handle in our day-to-day, which is around infant mortality, mother-baby, maternal mortality, and chronic disease. So a lot of these health systems, believe it or not, have not evolved themselves in the technology. As the world starts to move to these things called cloud, and they start having this data mindset, a lot of health systems actually haven't invested in the evolution of where the world is going. Lack of transparency. This is really around, if we think about it, we're taught to have a coordinated care, that we come up with a plan and there's a care team involved. Healthcare doesn't, outside of the patient experience and the day-to-day front line, doesn't really think that way or act that way. There's siloed data, even at the public health level, or even at the health plan level, and most of the time, even at the provider health system level. You'll have someone have a spreadsheet of data that's vital to other pieces of the organization. And so this lack of transparency and this inability to share data has not been truly solved, and that's actually helped exacerbate some of the challenges we're having with the COVID pandemic. And then, of course, everyone believes that data as the currency is the answer, but what we have to realize is that analytics is an enabler. In your day-to-day as clinicians in the front line, it doesn't come to fruition right away in the conversations you might have, but the future will be around having better insight, better information around the patients that you care for, and not so much about what you know about them, but how to better help solve their challenges when they leave the four walls of the healthcare experience. Every business is a healthcare business. That's the future, right? This pandemic's not going away for a while, and it won't go away. We're going to have, the virus isn't just going to disappear. It's going to stay. So regardless of the political winds of change or a vaccine, we in the front lines will still have to be mindful. And it turns out that this has created a new future in that even the restaurants and the grocery stores and all our interactions in our social lives in the economy are going to have a notion that they have to provide safety in our schools, and even going to your offices, that patients are going to want some sense of confidence, trust, and safety. And I love that Dr. Ertz brought this up just recently, which is this need for expanded mental health. We often think of a transactional experience with a patient, although we're thinking of 20 million problems. We're trying to figure out the top 2 or 3 that we have to address in that one visit. But mental health is so tied to a lot of the social determinants of health, a lot of the social factors, and it's the least invested in and not addressed. So even when you want to refer somebody over to a mental health specialist, most of our patients in these vulnerable populations who've experienced weathering and just chronic institutional racism and all those impacts are also impacted by the lack of access to mental health. And so what I'll share with really is, what does the landscape look like? What's the future look like for your practice and our experience? So one is collaboration. We're talking about unique partnerships, and we think of the ability to try and address the social factors outside of the 4 walls of the healthcare system. We have to talk about collaboration with community-based organizations who also tend to not trust health systems because they've been used before for research or access to patients for just trying to get to for a monetary empty pocket syndrome type of event where they're being used. And so we have to be better at those unique, meaningful partnerships. We also have to think outside of the box in terms of partnerships, not just with community-based organizations, but also industry, who will be leading this effort. The big bet in health in the industry really is around digital. That includes the digital experience. As we all know, Apple just released a new watch. It's going to measure pulse oximetry. We're going to see a lot of connectivity with IoT. In fact, most of the healthcare in the future, 50%, most of your patients will either get it from another entity or they'll get it at home. So how do we evolve towards that, and how do we make that equitable? Platform is really around how do we have systems that allow you at the point of care to know that Mike Petersen needs food pantry information or access to food pantry because he lives in a food desert, or he needs transportation or can't afford his medications at church. So giving clinicians that visibility at the point of care is going to be incredibly powerful. Despite all of these, with less than 30 seconds left, we talked about data. People spin around in data. There's a big bet on new care models, which you're going to be a big part of. You're already doing some of that work in the preventative care, but there's going to be a really around the people who have survived the most in this pandemic have those who did value-based type arrangements. Primary care sits at the center of all of this because these health systems and health plans cannot get to the patient without some interaction with you. So it's important that you stay in the as a very big key part of the solution in terms of delivery of really relevant, culturally relevant care. And that's it.
Thanks, Dr. Petersen. I hope you guys can hear and see me right now. My name is Phil McKoy, and I work here at United Health Group. And one of the things that I'm excited about is that our mission here at United Health Group is to help people live healthier lives and help make the health system work better for everyone. And amidst this global pandemic, the economic crisis, and all of the social unrest that started right here with the murder of George Floyd in my hometown, that mission is more urgent than ever. And our dedication to inclusion and diversity and health equity is a part of this and is rooted in our mission. And when we say we want to make the health system work for everyone, I mean, we mean everyone. And the current environment has uncovered or compounded those gaps in our healthcare system and has started a national conversation about health equity. And for us, health equity means helping people live their healthiest lives by offering them the care and support they need to achieve optimal health. But it also means eliminating inequalities in how people access and receive health care. And for more than 2 decades, United Health Group has focused on identifying and addressing and monitoring those health disparities. We focus on diversifying the healthcare workforce, and we've communicated with community organizations and national partners that are dedicated to health and wellness for all. In 2010, we established the Health Equity Services Program. And as a result of that program, we've been able to identify opportunities to better understand our members' unique needs. And we found gaps, and we're delivering new tailored solutions. We've developed action plans and initiatives that address health disparities, and we've launched industry-leading, no-cost accredited health equity education for employees and for providers. One example of this is where we identify gaps in care among Medicaid enrollees for postpartum care. And we were able to reduce disparities in timely postpartum care for Black women by more than 42% in Michigan and 83% in Ohio. Since 2007, our Diverse Scholars Initiative has provided more than $23 million to fund nearly 3,000 scholarships for minority undergraduate and graduate students who are pursuing careers as primary healthcare professionals. The Health Equity Services Program also launched health equity education for employees and providers to help them recognize and understand how health disparities can affect an individual's values, learning, and behavior. And in partnership with the Morehouse School of Medicine, the Centers for Disease Control, and the March of Dimes, this program has also developed provider-focused education to help address disparities in avoidable maternal mortality associated with childbirth. We've also partnered with Morehouse since 2013 to improve health outcomes in underserved areas. We contributed $1.2 million in philanthropic support from the United Health Foundation and Optum to help build health systems and health technology for tracking patient history and health outcomes for Morehouse School of Medicine's Patient-Centered Medical Home and Neighborhood Project. And our work with Morehouse also led to an 8.25 collaboration with the AUC to expand access to training programs for minority undergrad students to train and prepare the next generation of data scientists. And all of these efforts have been a long part of our longstanding commitment to enable and deliver equitable care and improve health outcomes for all. So health equity is core to what we do at UHG, at United Health Group. And technology, near and dear to my heart, is a major enabler in addressing health equity. In my role, I'm leading an enterprise effort to build a comprehensive digital and AI-enabled intelligent virtual and home-based platform to advance the quadruple aim of healthcare. And what we're building is a more intelligent system where all of the tools and technologies are available to consumers and patients wherever they are, where we improve the patient-physician relationship through real-time health information that makes it easier for patients and their doctors to make better care decisions. Dr. Petersen mentioned IoT, and our Vivify and Nerve Center tools are great examples of this, where we've equipped patients and our members with Bluetooth-enabled scales, tablets, blood pressure cuffs, and this allows us to monitor those patients outside of the doctor's office. When COVID hit, it impacted African-American, Hispanic, and low-income communities especially hard. And while we had been doing a lot to advance health equity prior to the pandemic really showed us that we must do more. We also realized that the intelligent digital information we were collecting and the capabilities we were already using could be deployed to help these underserved populations during COVID-19. For example, Vivify, which serves high-risk patients, became even more essential when at-home monitoring became critical for older and immune-compromised patients who couldn't risk infection by visiting the hospital. And our advancements in telehealth also became indispensable for access to care during COVID, not just for acute needs, but also for primary care needs as well. And the work that we did expanding telehealth technology to address the challenges of diabetes and obesity has informed our later efforts. In Tennessee, for example, our telehealth technology provided medical nutrition therapy and behavioral services at local community centers. And 35% of the patients who initiated those telehealth appointments had a decrease in their most recent blood pressure readings. And 23% experienced a reduction in blood glucose levels and BMI. And using the telehealth technology and tools improves chronic disease outcomes in vulnerable populations. And as we've all learned and seen, chronic diseases like diabetes exacerbate the effects of COVID. So we increased our telehealth support after COVID-19 hit. This included accelerating adoption of telehealth for communities at risk by supporting access to the internet and offering on-site logistical telehealth implementation support to key primary care and behavioral care providers. Finally, we established a COVID-19 medical intelligence tool to help identify and target hotspots that show communities with inadequate resources and high risk. And one of the things that I think about when I think about an intelligent system and how you make it more deeply personal, and Dr. Petersen touched on this, is how do you coalesce the reams and reams of information into an insight or a different recommendation? And then how do you take into account demographics and where we might have disproportionate health equity impacts based on those demographics? And in particular, when you think about the impact that COVID-19 has had on African Americans and other Black and brown communities, I think it's one of those ways that we can take our technology with that intelligence and create differentiated recommendations to physicians and to community care workers in ways that you might not be able to aggregate at the same speed in order to bring that real-time insight. Another important factor is that digital penetration among African American communities is really high. And so when we serve that community well with our digital offerings, it gives us a unique opportunity to impact those communities in a way that traditional approaches haven't been able to. And virtual visits give patients the opportunity to access caregivers that are more diverse. Technology can expand the aperture and open a broader world of doctors. Going forward, we'll continue to incorporate data from all communities to inform guidelines, training materials, processes, and tools that drive the use of advanced analytics and emerging technology to better address health inequities. We're going to continue to focus on people who have been underrepresented or underserved in medical research, including populations of color, pregnant women, and children. We'll continue partnerships like this one with the Morehouse School of Medicine to improve access to digital tools for underserved communities. And we're going to take what we're learning fighting COVID-19 and carry it forward to deliver more targeted personal care for everyone we serve. While we've made progress addressing health disparities and fixing inequities in the health system, we know that there is more to do. And we're committed to doing just that because it's our mission and it's our calling. Thank you.
Great. Thank you so much to all of our panelists. I think we are going to take the slides down and move into our moderated discussion now. And as we are getting into that, I'll just say, I think that all of the presentations that we just heard were really great and provided lots for us to think about the role of digital health, health inequities, primary care, and that's really why we wanted to invite individuals from various sectors to be able to share their experiences. If the panelists, Rebecca, Phil, Mike, if you can turn your cameras on, we'll go ahead and start the discussion, which in my view is the fun part of this, so we can all interact and really kind of bring everything that you talked about together. So I'm going to start with some questions targeting two individual speakers, but definitely want this to be interactive and really more interested in hearing you all discuss some of these issues together. So please feel free to chime in with your perspectives. And I'm going to start the first question to Rebecca. We really thought that it was important for this discussion to ground the audience and provide some of that foundational information about primary care. And it is such, as you described, such a unique setting compared to many of the other components of the healthcare system. And I wanted to thank you for your leadership in the survey. It's really provided some insight into what is happening on the ground in primary care settings. So you talked about some of the historical issues that have kind of plagued primary care, and then some of the issues specific to COVID. Can you tease out some of those differences a little bit for us, and really thinking about, if we want to set primary care, if this is our opportunity to set primary care in the center as the forefront, what are some of those changes that we need to see?
Sure. So big question, but I'll do my best to answer it and make it short. But yeah, so primary care has been anemically supported and funded by our government for about 4 decades. The result of that is that we are asked to do just about everything that can't be done in specialty care. That includes social services, public health, behavioral health, as well as primary care. And we're asked to do it with a third of the healthcare workforce and with about 6 to 7% of the national health expenditure. So we're stretched pretty thin, and we're about 98% efficient. We can't really get much more than that, and all the redundancy has been drained out of the system. Primary care clinicians are suffering a great deal right now, and the reason is, there are lots of reasons, but a big part of the reason is because they have a relationship-based model. So they are suffering when they have patients that are suffering, people that they know, that they've known for decades, that are not able to get the support they need. And they see it very clearly. Communities that are more vulnerable, communities that are more vulnerable to COVID, like African American communities, have been hit harder, and they see those families going down, not just individual patients, but clusters in families that are losing people to this pandemic. And it becomes excessively hard to figure out how to provide them support. So at the same time that we see primary care pulling back because it's having a shortage of personnel and it's having a shortage of income, we also see that when they say we have 30% of our patients experiencing food insecurity, they are adding services to help their patients with food insecurity. They are they've added on health behavior specialists. They've added on housing specialists to help these communities, because they're trying to fill in the gap that our country has allowed. The most eloquent person I heard speak about it said, really what's happened is we in the US have accepted the unacceptable. And in calling them social determinants of health, we rob all of the agency that exists actually within the clinical base as well as within the patient base. We say they're determinant of nothing. They are not something that is preset in stone. These are social inequities that are ingrained in the structural institutions in our nation. And if we can't understand that those are man-made and we can fix them, then we say that these are structural determinants. And what we end up doing is structuring our care around them and creating actually structural determinants of health through our care, not so much in our population. We contribute to what's happening. Primary care in the most ideal sense is actually meant to be where people live, work, and play. We are purposefully located in communities, in relationships. We work with area community resources, with public health and behavioral health, with social services, with schools. The idea is to provide a fully wraparound set of services, and we do 90% of what people need. And the things that we don't know how to do, we still take responsibility for. We say, we don't know how to do that, but we can refer you to somebody, and when you're done with them, come back and we'll help you to integrate that story and make sense of what it is. If we can't access you by computer, we will access you by phone. If we can't access you by phone, we will get a van and we will drive around under overpasses. We'll do whatever it takes to provide the care that people need. That's what this foundation is about. Now, that's not to say we're without problems. About 5% of the primary care workforce right now is anything but white, and that's absurd. So there are some very clear internal reflections that we need to do to fix dynamics, but it is a discipline that's born of mitigating social inequities so that everybody has an equal and equitable opportunity for optimal health.
Thank you. And I think that response, and you're really, highlighting the place that primary care plays within the larger health system. And I'm going to use that as a, pivot into a question for Mike as far as the relationships and collaborations and partnerships. You mentioned, I thought the every business is a health business was a really interesting point there, and interested in, what are some of these cross-sector partnerships? What are the unique players that have come into the system really out of necessity during COVID? How do we sustain those partnerships? And what do we need to have in place? And again, kind of thinking about the role that primary care plays there.
Yeah, how much time do you have? So in the short amount of time, Phil alluded to it, and so did Rebecca. And I think the key thing is the virus, the pandemic accelerated sort of the technological. So, people have been trying to work through. Remember, and I think Phil said it perfectly, is that, data and the technology are enablers. At the end of the day, what are they enabling? They're enabling human interaction. To Rebecca's point, though, there are only so many clinicians that can deliver this integrated care model. What we have to do in order to really get at a population level is to allow these unique partnerships. So if I met you while I was traveling at an airport and say, hey, did you know Ford Motor Company is going to make ventilators? You'd be like, what? So the way that we've been pushed into thinking outside of the box, we have to carry that forward. One example of unique partnerships didn't exist until the virus hit was in Seattle. Providence Health recognized that they had a population of people aging in place and had no access because of the stay-at-home orders to get food, and Meals on Wheels weren't delivering. So they partnered with Kroger, they partnered with FedEx. Never would these ever come together to match this need. And so I'd say that there's proof that we can think outside the box, and health tends to really kind of move slow. And I think what we have to do is kind of exactly what Phil is talking about, is that there are some experiences and there are some digital tools that we can try to use to leverage to get to people so they can make decisions for themselves. And I think about it, the Amazon experience for those in need, meaning just because we think people want help doesn't mean they're always going to ask for it. And to have people, the nice thing about primary care is you kind of know some of those needs. In my experience in the emergency department, they left the four walls of the hospital and I don't know if they picked up the medication. I don't know a lot of things. And so if we can really kind of get outside the walls of the hospital and help people in the communities, but it's really this collaboration piece has to be around what they're going to be doing in St. Louis, which is they're taking the Urban League. And I know United is kind of involved in this as well, but it's like Urban League, Barnes Jewish Hospital, WashU, along with other community-based organizations, but they're not just creating a one-off experiential, let's fix this one challenge. It's about building an operating model and a governance to truly address these things. And I'll say at the end, none of these collaborations can work without some insight to what Phil was describing, which is, as clinicians, you're going to need insight about your patients. You may know all the personal things, but at a population level, you might not know that a specific medication worked on hundreds of other patients in real time versus waiting for a study to come out. So these are the tools that we're trying to get to. There is a digital equity piece, and in one of the guiding principles that I've been helping some of our clients with is establish almost like an IRB for research, establish an ethical health equity framework so that you can actually be confident that all the efforts that you do, whether it's data analysis, algorithms, digital tools, start with that in mind, recognizing that anything you deploy as a digital tool has to be mindful of people who don't have access to those tools.
Thank you. And Phil, I know that did align a lot with some of the things you mentioned too. So if you want to add anything to that question or that response about the partnerships and early sustainability.
Yeah, it's interesting when you look at, it's always interesting to look at data, right? And, I'm a guy with a retail background trying to make it here in healthcare, but there's something to be said around how you segment your data around how people access information. And so if you were to look at sort of this broad topic of digital, it's not equal in terms of utilization and experience in the population and the communities that we serve. So for example, there's absolutely a digital divide when you think about urban access, rural access to things like the internet. But then there's some other tools like mobile devices, smartphones, where smartphones are much more ubiquitous in terms of how people use them. But specific to African Americans, 1 in 5 African Americans rely solely on mobile phones for access to the internet. And so you start to see these gaps in how people access digital tools and digital information. And then you've got to tailor your digital innovations and your care innovations to be aligned with how people access that information. And one of the things I get excited about when I think about the tools that we're producing and the innovations that are coming to market is, as more and more we shift to sort of evidence-based, clinical-based backing for a lot of the digital therapeutic tools that are out there, as we bring those to bear, we can actually utilize digital tools to be much more precise around who we access and who we touch. And I actually think that's what's going to sustain it, is that we stop with the broad brush of the same digital tool, the same program, the same measure of access for everyone, and get really specific around usage and usage by community. And then the other thing I would add onto that as well, and Dr. Etz, you touched on it in relation to a lack of diversity in primary care. I would also speak to the lack of diversity in things like behavioral care as well. I mean, I heard a stat the other day that only 4% of behavioral health providers are diverse. And that is also becoming an area where digital tools, mobile tools are becoming more and more common for serving and meeting health needs. And we also need to think about the population of the caregivers on the other side of that digital interaction as well.
Absolutely. And I think you're highlighting so many of these patient-facing, community, member-facing technologies, and really part of what the big onus for the digital health tool study and what we're doing here with this project at Morehouse is around whether the primary care clinicians that are serving these communities also have access. And that was some of the research that we had done, where the practices and the resources available within those settings sometimes are not supportive, and or they're struggling in different ways than some of the other settings. And I kind of want to pull trust into this a little bit too, on the primary care, on the clinician side, and also on the patient side. So can you all three really talk a little bit about how you're trying to, how technology and digital tools can be accessible or more accessible to primary care clinicians, and within, how do we build that trust needed for them to engage and for patients to engage with technology?
Okay.
Another big question.
So, yeah, I'll go first. And, I just want to make it a little muddy, if that's okay. Because this is a layered kind of issue. And I think we can all be grown-ups and admit that it's a layered kind of issue. So one of the problems is when you have a field like primary care that's funded largely on fee-for-service, even if there's some capitation, there's a great deal of fee-for-service. Fee-for-service doesn't include investment in technology. It's fee-for-service, right? So most other disciplines or professions, they get paid. Primary care gets reimbursed, and reimbursed based on what somebody else has decided is the likely cost for delivering care. And that's one of the reasons why it has been so far behind in the adoption of technology, because they don't get paid for it. So where does that cash come from? It was a huge outpouring of funds that they had to do when COVID hit in order to flip over. Half of the ones that are using telehealth now didn't have the software and didn't have the hardware before COVID hit. Nobody was paying them to adopt it. We were forced to adopt electronic health records and did so quickly because otherwise we wouldn't get paid. Nobody paid for those, right? The practices had to come up with that investment. By the way, they work on like a 2 or 3% margin. But one of the problems with the electronic health records is it's now even harder to get the data out. So you can get the digital tools, but they can't get the data out. We actually have no database, no national database for primary care, none. If you wanted to say, let's get that provider relief fund and get money out to primary care clinicians right now, we have no idea where the front door is. We don't know where to go. It's horrible. This is what it means to not support a profession. So we don't have the health information exchange. One of the outcomes of that is we have no measures to really understand what health inequities look like. We really don't. So you can't go into any standard database and pull out what does COVID look like for the African American population or the Asian American or the Native American versus the Caucasian. We have small data sets and people that we're trying to link together to try to figure it out because we don't have a national resource for that. The Institute of Medicine, before it became the National Academy of Medicine, put out a recommendation for vital signs, what they felt were the most important population health measures we should collect across the country. It doesn't have a single health equity measure in it. And they say it's because that's involved in everything, right? Like you always have to pay attention to it. As an anthropologist, I'm here to tell you this is exactly how structural inequities work. By not causing a lens to focus on them, we allow people to believe that they're doing a good job, right? They like to think well of themselves. We allow them to not quite see the magnitude of the issue, and so it continues, and we don't realize the way in which it continues and gets perpetuated. So fee-for-service is a great example. How does fee-for-service work in a population that doesn't often need procedures, but needs a whole lot of chronic maintenance? Or what does it mean to support telehealth and not pay attention to who has broadband access and who doesn't? To have phone not supported during the pandemic, but to have video, when many people don't have broadband and they don't have the computers, but as Phil was saying, they've got phones. Everybody's got a phone. You know, even folks living under the bridge have a phone and they can use that. It's a huge, huge issue that we have to try to solve. How we get that information exchange happening across these digital platforms, how we mine the data in a meaningful way, I think is probably one of the biggest traps for digital health that we haven't faced yet.
I don't know how much time we have left, but
you have time.
Okay. My thought is, when you focus on trust, we have to understand that, yes, people may have cell phones, and Becca just alluded to this, is that they may not have the data plan to use it. So you have to kind of think outside the box. But in terms of trust, it isn't, I think our industry in the past has always just said, here is a digital solution, now go forward and heal. And what they don't realize is that they didn't do what was needed from the beginning, which is human-centered design, and not just from a person, but also from a culture. So in the same way that my mom consumes health, which has got a Latin American, Hispanic point of view, it's different than someone who might be African American in the same city. So you have some data that can give you some insights. What's really scary is that we woefully give so much data that it turns out Amazon probably knows more about us and our health and the things that we're searching for in Google, that more than the health system would know. And there's some, thank God there's mindful thinking around that. But from when I say a human-centered design, it starts there, but also evolves people from the community to help in the solution that they're trying to solve for. One thing to state is that you can't solve it all by yourself. So if any company thinks they're going to solve it by themselves, they will be met with significant disappointment. So it is really about an ecosystem of partners for the right use case. So I think Phil said it perfectly. You can get all this data and people spend hours and hours trying to qualify and get it perfect, but it's actually trying to get directional and fast failing to a point where you can actually use it. And so we did that like in infant mortality. We really got to this 360 view of moms and understanding, because we broke those barriers of silos of data. So you can really understand the consumer behavior, the consumer thinking. And one last thing I'll say is there is trust, right? We all kind of get a little sketchy when we think about Facebook and what are they doing with my data versus Apple, who's selling it, that you can trust us. We're the security brand. That people who often mistake that because people are poor or live at the margins, that they have a different expectation. They have the exact same expectation for consumer experience that we do, which is the industry big bet around trying to create an experience that people will use when they want it, how they want it. And the last thing I'll say actually is that primary care is going to be at the center of all these digital evolution. So what's going to happen is your patient's going to say, hey, what do you know about Lemon Health? What do you know about Livongo? What do you know about all these apps? And by the way, you keep telling me I got to lose weight. I got this wireless scale. is there a way I can get it to your hospital system and you can know how much I weigh if I had water weight gain? They're going to be pushed in. And so other companies are going to solve that for them in trying to, Best Buy is thinking about sending Geek Squad Health to set up all these IoT devices. But the person who's going to receive all this is the primary care physician. And they're going to, in that 15-minute visit, they have to figure out 90% of what they just talked about. So I'll stop there.
I would imagine, Rebecca, that the question there is, how does the fee-for-service payment cover that role there too, right? or how is the primary care clinician getting paid for serving in that role? We have about 5 minutes left until we go into some audience questions. And really, I just want to focus. I think we've talked a lot about some of the opportunities, but specifically, are there policies or practices that have been responses to the COVID pandemic that we need to see continue beyond the pandemic? And if you want to, respond in the other direction as well, are there things that we have put in place that we absolutely do not need to keep in place, but just top of mind, the policies that have been put in place to support telemedicine, and for the example that Rebecca, Mike, I think all of you have touched on, Phil for sure, being able to use just the phone to talk to a patient and still be able to bill for that. That was a huge change that we would have had not happened before. But yes, talk a little bit about what's been put in place, what needs to stay in place.
Maybe one thing, sorry, Dr.
Go ahead, Phil.
Go ahead. No, just the one thing I was going to add to that list is the support for interoperability and the sharing of data. Like we've all sort of touched on that, on the edges, but that becomes a really critical component of the ability for standardization and open access and sharing of data across the health ecosystem becomes a really key enabler of digital health for patients, and then also the way the physicians work together from primary care to specialists. And so I think to the extent that we can continue to see the ability and the standardization of how that data is shared and how interoperable we are, that'll be a really important trend to keep going as we move forward.
I would say to your policy question, and I'm probably going to have a lot of people who will jump on me, and that's okay. I don't know that we've done anything policy-wise that's been any good. If I were pragmatic, I'd say keep up telehealth and phone at parity. But if I were being honest, I would say that as a country, we have accepted the unacceptable, and it's time to muster within us the political will to say we won't do that anymore. Primary care is a social good. We treat it as cost containment in the US. In other countries, they treat it as investment in community health. Those would be the countries where they don't spend nearly as much and their health outcomes are better. Whereas in our country, we spend almost twice as much and we're losing weeks of life expectancy every year now. It's the worst case scenario. So, primary care is a basic social good. There is a need for the public support for health, and we should find a public health way to pay for that. I would also say one of my hesitations about saying telehealth at parity is that it supports paying for primary care as a cottage industry. When we talk to a lawyer or when we talk to an architect, we don't tell them when it's appropriate to do that via phone or when it's appropriate to do that via email, but we do that to doctors and we don't trust them to make that decision. I'm not saying it has to be, full capitation, but we need some kind of reliable, prospective payment that's predictable, that allows us to have a long-term view and make the investments in our practice and our communities that best benefits their health. We only do that by getting away from a fee-for-service model.
You are getting some kudos in the chat box. Just not anybody jumping on you in the chat box, at least yet.
She's looking for a fight.
Sorry.
I can tell. She's like, I'm going to say something that's going to mess. No, I think and I'll say I'm not a policy expert, but at least one thing, and it has to do with telehealth, is that there's this excitement about telehealth is going to be the answer. And we do know, again, it's a tool. When they changed some of the rules to allow clinicians to just, because they were also couldn't go to the office, right? So how do I see my patients in most need? They did, I would say, relax some of the rules that had to do with, if I can use WhatsApp versus, some sort of Pentagon level military security. I think that access helped. And I think that's something that we need to rethink. We know that they're probably going to pull that back a little bit in the sort of effort of safety. But I do think that there are some telehealth sort of impacts that could probably be more relaxed, at least from an access standpoint. And especially when we think of the pandemic, people who are most impacted are those who are obviously challenged by who can't go and you have transportation barriers, et cetera. So I do think that that's one area that might be helpful.
Any last comments before we go to some audience questions? Okay. I think that Mitchell has been reviewing those as they've been coming in, and he's going to come back on and provide some of those for us.
Yeah, sure. Thank you, Megan, and thank you all of our panelists. We did have quite a number of questions, and thank you to our attendees. Some of them you've already addressed, and so we're going to go to more of some of the direct ones. And this is to anyone, what have you seen with respect to the adoption of these technologies with communities that either haven't had access to technology or are not as comfortable using technology, especially in older populations of color? So again, what have you seen with respect to adoption of technologies with those who don't have access or are not comfortable using technology?
Well, I mean, I can take that one. I mean, and I touched on some of those metrics. I think you have to understand how the technologies are being used, right? And we've traditionally built a lot of our health tools as desktop-based tools, when in many communities of color, the greater penetration is through mobile. But the mobile sort of expansion of the experience, it trails what we've done for desktop. And so I think that we've got to do a better job of understanding how these digital tools are used and have that guide how we implement them. I think that's a very important piece of it as well. And then the other piece, and I would just give a plug, I also think it can be influenced by the diversity of the individuals that people interact with in the health system as well, that are proponents for usage of those tools. And that's why I do think it often comes back to how do you engender the right trust in the health system by having a more diverse population of health workers, whether it's nurses, physicians, whatever it might be, that are involved in people's care.
I do think there's an understanding. You have your silver surfers, or people like my mother and father-in-law who are very tech savvy, or my mom, who I purchased an Alexa device, an iPhone, an iPad, of which she used none of them. So there is this, you have to really kind of understand, again, back to that human-centered design piece about, really, and I think Phil alluded to this too, is that you can get down to the data and really understand and let people choose how they want to interact. You're just gonna have some people who want to fax you something and you're like, fax machine. So whether it's email, phone call, all of those sort of multimodal, or we call omni-channel experiences. And the last piece is it has to be easy. Why do we love Amazon? Why do we love our bank apps? Why do we love all these other tools? We make it complicated in health. For me to get my information from my insurance company on whether a claim was paid, or they're badgering me saying, hey, it hasn't been paid. And then I'm calling my physician about it. That shouldn't happen. I mean, that doesn't happen in the experience of Amazon. I can just click a button. I don't have to call Amazon. Usually I start off my conversation with, how many of you call Amazon to find out where your gift is, where your package is? And most, except my dad, would raise their hand, right? So it is about this experience. And that's where the big bet is being made, is that your patients are going to say, hey, I just experienced the Walmart Health app and it was phenomenal. I got everything I needed. I had a telehealth medicine. I got to choose the color of the clinician to see me. I'm not saying that's what they're going to do, but that's how people are going to evolve, so that you will get to see, you just get to consume it from an experience that is, as you know, we're kind of lazy inherently. And so we just want things easy. None of us want to make a phone call anymore, right?
I also just wanted to, add there, and a member of the care team that we really haven't mentioned right now, but community health workers and the role that, they can potentially play to walk patients through, if they're not able to get their telehealth visit, going with the instructions. But, I think that it is important to recognize that we need, and some people are going to need that hands-on care.
Yeah, absolutely.
The community workers are actually a great example. As I mentioned before, we do not have a medical workforce that reflects the population, or that's representative of the population. And a lot of practices start to employ community health workers as a way to correct for that, because correcting for it through the professional workforce, frankly, takes longer. And we can't wait that long. People need help right now. And they need appropriate help right now. And community health workers, peer mentors, peer support, behavioralists, these are all people who are really, really helpful for those sorts of things. They are not billable, so we don't get to pay for them in primary care. If we simply paid for the service and the platform, and that it be present, then we could reach out to patients, whatever their preference. Right? Whether they wanted to do you can actually do the PHQ-9 through Alexa. We could reach them however they wanted, in whatever way they wanted, whenever they wanted, and that's what we're meant to do as a platform.
Yeah, I'm glad you brought up community health worker, Megan, because Scott Tornick at Impact at UPenn, their whole focus is on leveraging community health workers and trying to show that it's actually the right investment, and the dollars that they actually save a health system and the quality of care that they bring in. One thing to point out is that there will be, we hope, through the Gravity Project, right, some ICD-10 codes for some of these services. So the ability for a community-based organization or a community health worker to start to bill for some of these social healthcare factor efforts, it might even come down to education on technology. That's the thing. The pace of the technology is moving so fast that even as I can't keep up with half the apps my teenager uses, right? So think about that in the health system when our patients are coming to you with, Doc, what do you know about these 5 apps? And you have to give an educated answer on it.
That's true.
Awesome, thank you. I had one very interesting question, particularly given trajectory of where we're going right now, directed to Dr. Petersen. What are the most important things we can do to build trust and ease logistics of getting vaccinated in our local community? Given that now, we're working on COVID-19 vaccine, and also we're approaching flu season. So what are the most important things we can do to build trust in our community?
Yeah. So if you think of the flu vaccination rate minus COVID, it's not that high, right? And we look at the common annual deaths as real. So there's 2 things that are part of, one is that, we'll talk about the COVID vaccine coming up, but public health messaging is so vital, right? How people consume the messaging. And so as clinicians or frontline workers, it's really around what you do already, which is you encourage. And there is this decision-making process that the patient's going to say, I'm going to take my chances. So it's really wrapped around what are you messaging and how might it help them? And especially now with this complication of flu plus COVID, and now a COVID vaccine that you have to take twice in order for it to work. I think it's going to be based on the relationship is going to be key. And then being honest with the patient. If they say, hey, what do you know about the immunity of this? It's okay to say, I actually really don't know, or we know that it doesn't work this way. They show that obviously the more honest we are with our patients and we gain their trust from that perspective. I do think that they're going to see mixed messages. So there are actually businesses out there that focus on helping hospital systems manage the wrong messaging and misinformation. They will scan all of the social media and say, these are what your patients are talking about. So when we think about data and all of the technologies influencing people's decisions, I think the place that we would serve as clinicians is to be sort of that sage advisor, but also at the same time, my motto when I was in Children's Hospital for residency is, when you do what's right for the kids, no matter who gets mad at you, as long as you stick with that, people can get mad, but as long as you stick with that mantra. So I always say, just do what's right for your patients, what you do every day. That'll be the best thing for you. I hope that answered it.
I believe so. Thank you. And just one final question. I'm going to try to wrap up all of the rest of these in kind of one big nice bow. How much do you think new digital health technologies can potentially impact how data is collected and aggregated in a more equitable way? And how do you see this changing within 2 years?
2 years.
Did you say 3 years?
2.
2, gotcha.
So this is to all of our panelists.
I'll let Phil or Rebecca go first.
That's so nice of you.
I think it's good. I think it's going to change it dramatically, right? If you think about access to care and usage, right? As more and more of these tools become more ubiquitous for health purposes, it adds to the level of data that's out there. And so I think you're going to see a dramatic increase in the level of data that's collected from a broader cut of our communities and our population. The piece I would add to that, though, that I think is really important is it's not just about collecting the data. It's also about the way in which you analyze it. And so there was something that I mentioned in my comments that, I mentioned quickly, but I want to come back to is, you'll see one of the things that we've done is we've made a material investment in the AUC specific to data science, right? And so it is equally important, not only in care delivery, but it is also equally important in how we think about the analysis of the data and the conclusions that are being drawn, that is being done by a diverse population of data scientists and analysts. So it's not just about the fact that we're going to have more data. I actually think in some cases, it's more important that you also have more diverse people analyzing that data and driving the conclusions and the insights and the actions that gets taken on that data.
So here, absolutely. And I would say we've already started to see some generational shifts, right? We have a generation now that pays more attention to their own health behaviors and self-monitoring than they ever have before. We have an explosion of wearables that provide us all kinds of information. We are always going to need a human who makes sense of this data for us and helps us to understand what it means. What we have not really appreciated is that in our direct to consumer sort of selling of these things and propagating of these things, we have created a huge amount of information that has very little workforce that understands how to analyze it. And you have actually doctors who get a lot of calls now because people are wearing an iWatch that tells them that they have an arrhythmia, or they were sitting, while waiting in traffic and anxious, and they checked their heart rate and they think they're going to die now, and they got to talk to a doctor to figure out what it means. We provide pacemakers that do these constant updates of how things are going. That we don't understand the difference of signal to noise, but we've put the stuff out there and the noise is getting in our way. And the need to develop an information science that's specific to how as a primary care office do we take in this tremendous influx of information like you were talking about before, Michael. We have to take in all this stuff and in that same short little period, make sense of it for you. while also paying attention to all the things that we are professionally aware that we need to focus on that may not be at the top of your agenda, but really matter a tremendous amount to your health. So how we do that part of it, I think, is really concerning. We know that our population is getting chronic diseases more and multiples of them, but we also know that it's happening later in life because of that focus on prevention. We know that we have a population that is far more mobile. We also know we have a population that chooses not to seek care in their 20s and 30s as much as they used to. And so when they finally do get somewhere, they don't really understand what it means to have a relationship until they're faced with a critical event and they need some wise counsel. And then they feel lost. So I think part of what we need to do is we need to explain what the nature of that relationship is and what it can provide you, as well as kind of figure out a way to manage what all these wearables and influx of information needs, because they are continuing to explode.
Yeah, I'll chime in real quick, is that the data can be biased, right? And the fact that a human, as Phil and Rebecca just both alluded, is that there are human beings evaluating and creating the algorithms and letting machines build. And we have horrible stories about this, right? We know about Amazon redlining on where to put Prime. We know that when they look at prison recidivism, it always predicts that an African-American or person of color is going to be the one most likely to commit a crime. We have to be incredibly smart, and that's part of the business I help lead, which is helping health systems be framed in every aspect of their business in terms of the data science piece. So all the algorithms, machine learning, that they start with almost like an IRB. It has the checks and the trust. We call it more veracity around the data. More, and then at the patient level, I think Rebecca called it perfectly, which is, when I was asked for discharge in a newborn, the mom would go, "I just want that pulse oximetry machine at home." I go, "No, you don't. It's going to alert the baby's going to pass gas the wrong way, and you're going to call 911. So we have to also educate as primary our patients to understand what the noise might be, and we always taught in medicine, don't treat the numbers, treat the patient. And so we have to think about what the patient is experiencing and have them. And so there's a health literacy that has to be thought through, but not only just a health, but a data health tech literacy that we want to, that could be a 4-year degree for people around how do we help patients around that. So I think that it's about algorithms and being really, really smart and mindful and careful of the data. If you think about the recent Accenture Google data sharing, they probably went through all the safety checks that one would say, but it's the perception. And so brand and the trust in brand, which is why Apple is saying, you can trust us. Anything that comes and touches our phone, it's safe. And people want that security and that confidence, especially in the world that we live in with all this enormous amount of data.
Absolutely. And I think that's a good point to end on. I know we could talk about all of these issues for another hour or more. But thank you again so much to each of you. We really do appreciate you giving us your time, your wisdom, sharing all of these pieces with our audience today. I also want to thank United Health Foundation for supporting this event and the larger digital health tools study. Want to remind everyone, Mitchell mentioned the survey that is part of the digital health tools study that we're conducting with primary care clinicians in Georgia, Kentucky, North Carolina, and Tennessee. The link is in the chat box right now. If you are not a clinician who can take that survey, we still want to partner with you, and you can find that information on our website. For those of you eligible for CME, don't forget to get that. And I want to thank our audience for being here. You all asked great questions. I was really impressed, even with those that submitted during registration. Really appreciate that. And finally, thank you to the Digital Health Tools Study and NCPC teams. Danita Walston was behind the scenes, but really did all of the heavy lifting for us. Mitchell, Dr. Mack is our fearless leader, Dr. Ann Gagliotti, and many others. So thank you, everyone. Have a wonderful day, and we appreciate you.